Our presenter today is Dr. Betsey Bean. Dr. Bean is a fellowship-trained hand and upper extremity orthopedic surgeon. She is board certified in orthopedic surgery from the American Board of Orthopedic Surgery. She attended medical school at Des Moines University College of Osteopathic Medicine on an Army scholarship. She then completed her orthopedic surgery residency from Madigan Army Medical Center in Tacoma, Washington. Following residency, she served for 4 years on active duty service in the United States Army at Fort Riley, Kansas. During her active duty service, she deployed with a forward surgical team to Syria in support of Operation Inherent Resolve. She then went on to complete hand and upper extremity fellowship training at WellSpan Health in York, Pennsylvania. Dr. Bean joined McFarland Clinic's hand surgery and orthopedic surgery department in August of 2021. Please welcome Dr. Bean.
Hello, thank you for having me. It's an honor to be here. So most of my practice is focused on hand and upper extremity problems, and I'd say the vast majority of my patients are older patients because that's when we tend to develop more osteoarthritis and tendon problems and things of that nature. So I talk about this stuff every day with my patients. It's fun for me to talk about. Hopefully it's educational for you and beneficial for you too. So we will talk about problems like osteoarthritis in the base of the thumb, which is very common, in the small joints of the fingers, and then in the wrist as well. We'll talk about nerve problems like carpal tunnel syndrome and cubital tunnel syndrome. We'll also discuss tendon problems such as trigger finger and Dupuytren's tenosynovitis. And then we'll also talk about some other problems that we see in the hand that aren't necessarily always painful, but are very common things that I see patients for. This slide is just for some clarification. So I often refer to corticosteroid injections simply as steroid injections. A lot of patients ask me, are you talking about a cortisone injection? Yes, it's all the same thing. They're medications that we use to inject into joints and tendons, and there's different brands, but they all work in about the same fashion. So I'll say steroid injections in my talk today, but that's what I'm talking about. And then I'll also, on a lot of the slides, you'll see NSAIDs, and NSAID stands for non-steroidal anti-inflammatory drugs. These are your ibuprofen, Advil, naproxen, Aleve, Celebrex, meloxicam, those medications that work really well for musculoskeletal pain, but have some potential side effects, especially if you have kidney disease, and you have to be careful if you're on blood thinners. So they do work well, and I'll leave it at that. But if you're having to take them more regularly, have a conversation with your primary care doctor about the safety of that. Okay, first, we'll talk about osteoarthritis. So what is osteoarthritis? It's degenerative joint disease where the tissues inside the joint will break down over time. This is your wear and tear arthritis. The cartilage in joints, the cartilage is the end of the bone, and so a joint is two cartilaginous surfaces that glide together. And as osteoarthritis progresses, you wear away the cartilage and you end up with a bone-on-bone joint, which is painful. You can also develop bone spurs, which is what the bone does in response to more stress. It responds by getting bigger, and those are the bone spurs on the periphery of the joint. The joint can lose its normal shape because it's responding to the stress and developing more bone spurs. And sometimes those little pieces of bone will break off into the joint, float around. That's called a loose body. This can be caused simply by aging, but a lot of times we'll also see it if patients have previous injuries to the joint or maybe even previous surgeries in the joint. We know that family history does play a role, although we don't really know how to modify those genetic factors yet, but it certainly does contribute. Symptoms of osteoarthritis, typically patients will have pain, they'll have joint stiffness, usually worse in the morning, tends to get better once you get moving. Motion loss will also decrease. That occurs because the cartilage wears away, so you no longer have a smooth joint surface that glides together. And then sometimes bone spurs can cause a mechanical block to motion, so you simply can't move it any further. And then the soft tissue around the joint can also contract and make everything tight. Swelling is common. You can get swelling inside the joint itself or sometimes in the soft tissue around the joint. And then grinding and popping are also very common as you wear away the cartilage. We diagnose osteoarthritis mostly by physical exam and x-rays. Sometimes an MRI is useful in the early stages because you may not see evidence of mild osteoarthritis on x-rays. And occasionally we'll do things like draw fluid from the joint and evaluate that fluid in the lab if we're also concerned that maybe there's gout or infection or other things that are contributing to the joint pain. There's no way to really cure osteoarthritis. We don't have a way to regenerate cartilage now. So the goal of treatment is to decrease pain and improve function. And that's primarily done by modifying activities. So we decrease the high impact activity, do more low impact exercise. Medication like those anti-inflammatory medications, ibuprofen, Aleve, Celebrex, those things help. Sometimes braces or splints are really helpful. We use those a lot in the hand and the wrist. Physical therapy can sometimes be helpful, especially for the soft tissue contracture that can contribute to some stiffness related to arthritis. Steroid injections, we do tons of steroid injections in hand surgery because it's pretty effective for a lot of joint pains. And we'll talk about that more specifically when we cover the different locations of arthritis. There's some other injections that might be helpful, like blood products, your own blood that's spun down and re-injected, although the research is still a little bit inconclusive. In the knee, there are like gel injections. Those haven't been approved for smaller joints in the hand, so we don't use those in the hand. And then surgery. Surgery is useful when everything else fails. A lot of people ask, when should I have surgery? It's all based on symptoms. So if you can live with your pain, you don't want to have surgery and go through the recovery, then just keep doing what you're doing. But surgery is effective when it's no longer manageable. There is another type of arthritis, inflammatory arthritis, which is different than osteoarthritis. And inflammatory arthritis is a collective term that refers to different types of arthritis, like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, lupus. So in contrast to the wear and tear type of osteoarthritis, inflammatory arthritis happens when your autoimmune system goes a little haywire and starts attacking the joint. In rheumatoid arthritis, we see this as the lining of the joint gets very thickened. That's called synovitis. And then you get destruction of the joint. It causes erosions to the bone. In psoriatic arthritis, it happens similarly, and you get very misshapen joints that look different than a standard osteoarthritis looks on x-rays. It can also cause some generalized inflammation throughout the body that affects the internal organs, whereas osteoarthritis doesn't do that. The treatment of inflammatory arthritis is geared toward calming down the immune system to prevent the destruction of joints. And those are that you do that with special medications that a rheumatologist manages. And steroid injections, some anti-inflammatory medications, those can be useful too for inflammatory arthritis, but what we really try to do is simply prevent the destruction of the joint with those special rheumatology medications. And then if the destruction has occurred, then the surgery that we do for inflammatory arthritis is very similar to osteoarthritis if it gets to that point. So if I often ask patients, do you have any history of inflammatory arthritis like rheumatoid arthritis? If you've reached this age and you don't know, you probably don't. And most people have osteoarthritis. So first we'll talk about arthritis at the base of the thumb. We call this basilar thumb arthritis. The joint is the carpal metacarpal joint, so it's also referred to as thumb CMC arthritis. This is a very common location for arthritis 1 in 4 women and 1 in 12 men will have arthritis at their thumb CMC joint on x-rays at a certain point in their lives. Not everybody has pain related to it, but it is very common to get arthritis here. Symptoms of thumb arthritis include pain. That's usually what people present with. They feel it at the base of the thumb. So right where this circle is at, that's where most of that pain is experienced. It makes it difficult to pinch and grip tightly. Patients often have difficulty putting a key into the ignition or taking the tops off of jars, or holding a heavy book. You can also develop some deformity as the arthritis progresses. And the reason why is because you get arthritis down at the base of the thumb. It causes this bone called the thumb metacarpal to contract into the hand, and then the joint above it, that's called the MCP joint, that hyperextends, and it's trying to compensate for that motion loss. And then this joint at the end does the opposite motion direction for compensation. So you end up with this Z deformity of the thumb. Doesn't always happen, but it's not uncommon to see that in really advanced cases of thumb arthritis. Diagnosis is made with physical exam and x-rays. That's typically enough to make that diagnosis. So treatment. Treatment includes all of the standard non-operative things like anti-inflammatory medications, use of a thumb brace, steroid injections, and they work reasonably well for most people. There's probably 100 braces for thumb arthritis on the market, and I don't have any connection to any brace, but the idea is support the joint but still allow some function. If you can't move your thumb, it's not a very functional brace. Most people won't wear it. So these are two very popular braces that are useful, that can be worn intermittently for thumb CMC arthritis, and I prescribe a lot of those. Steroid injections work well. Most patients get 3 or 4 months of relief out of a steroid injection, if not longer. We don't walk on our hands, so arthritis progresses at a little bit slower rate because it doesn't see the stress like a knee or a hip does. So steroid injections do work pretty well. And then surgery. So again, when's the right time to have surgery? When you have pain that's no longer managed with all of the other things. You can never wait too long to have surgery for a problem like this. Surgery, what we do for it, depends a little bit, probably on who you talk to, but I'd say the vast majority of surgeons do this procedure where you remove a bone. So we remove the trapezium bone, which is the bone below the thumb, and that forms one surface of the bone-on-bone joint. So we remove that and then fill in that space with a tendon and try to keep the thumb suspended with use of that tendon that holds it in that position. Unfortunately, we don't have the research or the technology yet to do like a knee replacement or a hip replacement for this joint. Maybe in the future they're working on it, but right now there's no good treatment options like a joint replacement. So we just remove that bone. And sometimes if you do have that Z deformity of the thumb, you need treatment for the joint above it to correct that as well. Recovery in total, somewhere around 3 months. That first month is in a splint that you leave on most of the time, or a cast that stays on full time, and then you need another couple of months of therapy. So it's a commitment, but most patients are happy with it in the end. Finger arthritis. So a lot of people, I should say, as we get older, will develop some angular deformities in our fingers, which is in most cases a result of arthritis. A lot of people don't have pain, but sometimes you do. And so when we see deformity plus pain and maybe some knobby type of appearance or bony prominence to the joint, that's all very consistent with osteoarthritis in the small joints of the fingers. Physical exam and x-rays are enough to diagnose that. And treatment always starts with those same non-operative treatment things that I mentioned before, like medicine and finger splints and steroid injections. If it gets to the point where that's no longer good enough, then surgery works well, and the type of surgery depends on the joint. So The joints that are nearest the fingernail, those are called the DIP joints. Those are the little joints of the fingers. That's these blue circles here. And the surgery for that is effusion. So we remove any remaining cartilage and use a screw or some sort of internal fixation to bring the bone pieces together so that the bone grows together, which means it no longer moves, but it does help to eliminate the pain related to the arthritis. In the other joints of the finger, like these middle joints called the PIP joints, or the knuckles called the MCP joints, we do joint replacements. And this picture on the right, this is what a joint replacement in those fingers typically looks like. This is made of silicone and it's a hinge. So you make space for it in the joint, and then it goes inside the canal of both of the bones, and it allows for motion at the joint and removes the pain from the arthritis. That is a very long history that's successful. They've been around for several decades. There are some other types of joint replacements that are like metal and plastic, much like a knee or a hip, but those don't have quite as long of a track record. Wrist arthritis. So wrist arthritis is also pretty common, but not as common as arthritis in the thumb or the fingers. When you develop wrist arthritis, there's usually a reason for it. It's usually not just simply related to wear and tear. So patients that have a chronic ligament injury between the bones of the wrist, like this big gap is evidence of a big ligament injury. That leads to a very specific type of arthritis in the wrist. Previous fractures that haven't healed, like the scaphoid bone, that's this bone here. This is an old fracture that never healed. That leads to a very specific type of arthritis in the wrist. You can also have inflammatory arthritis, like rheumatoid arthritis, which really leads to arthritis everywhere in the wrist, as opposed to specific areas of the wrist joint. Symptoms. So pain with wrist arthritis is kind of diffusely located around the wrist. It's hard for people to point to a spot that really hurts. It's just the whole wrist. And there's often swelling, sometimes some ganglion cysts or little fluid-filled pockets that will also develop related to the arthritis. Stiffness is very common, so the wrist just doesn't move like it should. And we can make this diagnosis with our physical exam and x-rays. Non-surgical treatment includes wrist brace, steroid injections, oral medications like anti-inflammatory medications. They all work reasonably well. And then surgery also helps very well when you get to that point. And there are different types of surgery based on where the arthritis is. Surgery usually consists of removing bones in the wrist or fusing bones together, which when I have that conversation with patients, it sounds a little bit scary to think we're going to take bones out of my wrist or fuse other bones together. But again, it has a long track record and it does work very well. So like this picture up here, this is a patient that had their whole row of wrist bones removed at the base. That's called a proximal row carpectomy. That works really well. And it eliminates the need for a long time in a cast because you can start moving pretty quickly after surgery. And by removing this bottom row of bones, you have this good joint surface on this bone, which still forms a joint with a good surface on the radius bone. So that works pretty well for a lot of people with wrist arthritis. Sometimes you can't do that just based on where the arthritis is. So you have to take out a bone and then fuse other bones together. This is a little plate on the back. That's what we commonly use to fuse those bones together. Sometimes if there's wrist arthritis that's more diffuse and you don't have any spared cartilage or any bones that are still good, then you have to fuse the whole wrist. So this picture is a plate that goes across the end of the radius bone into the hand. And in this surgery, you can't move your wrist anymore. You can still rotate the forearm, but there's no wrist motion like this. So that clearly eliminates or interferes with some function, but does do well for pain if you get to that point. But we try not to do that unless we absolutely have to. And then joint replacement. We don't use joint replacements that often in the wrist. There are some patients that it's appropriate for, but we don't have the research and the technology like we do in knees and hips that have made a good joint replacement implant for us to use that's reliable and has will last for a long period of time. We know that if we fuse the bones and with a plate and screws and get them to heal together, that really does do well, although you eliminate some motion, but that has a much better track record than a joint replacement. We might get there in the future, but not quite yet. It's usually not the right answer for most people. All right, moving on. So now we're going to talk about nerve entrapment syndromes. Carpal tunnel syndrome is the most common nerve compression syndrome in the upper extremity, and it may affect as many as 14% of the general population. We see it often in the 50-year-old population first, and then it peaks again in your 80s. We can see it in anybody, really. I just had a patient last week who was 20 years old that had really severe carpal tunnel syndrome, but my common patient population is older. What is carpal tunnel syndrome? So it's compression of the median nerve in the carpal tunnel. Where is the carpal tunnel? It's in the wrist. So it's formed by the carpal bones on the back, and then there's a ligament that forms the roof of the carpal tunnel. Through that tunnel, there are 9 tendons and then the nerve. The nerve is the median nerve, and that nerve is responsible for sensation in the thumb, the index finger, the middle finger, and this half of the ring finger. It does provide some sensation on the back of the fingers, but only to this middle joint here. There's other nerves that supply sensation elsewhere. So most patients, when you're experiencing carpal tunnel, will primarily experience numbness and tingling. Pain is also a symptom, but usually the numbness and tingling are first and foremost, and then the pain is more of it comes on toward the end when numbness and tingling gets really bad or is really dense. Most patients will experience numbness and tingling at nighttime when they're sleeping, but also some daytime activities like driving, holding a book, reading, holding your phone. Those are very common activities that will cause that numbness and tingling, which is usually related to wrist position. So if we are doing activities where the wrist is flexed for a longer period of time, then that compresses the nerve more than a neutral position. In more severe cases of carpal tunnel, you can also see some shrinkage of the thumb muscle, or what we call thenar atrophy. Atrophy is where the muscle shrinks. And it happens because the nerve signal isn't reaching the muscle. So the muscle just doesn't have any signal to fire, and it becomes smaller. So this is a picture of thenar atrophy where you see this divot where there should be muscle. Risk factors. So there's really strong evidence that higher BMI and higher hand and wrist repetition activities will contribute to carpal tunnel syndrome. There's moderate evidence that things like rheumatoid arthritis, perimenopause, wrist tendinopathies, which we'll get to later, even gardening, computer work, assembly line work, those things can also increase risk of carpal tunnel. And we know that exercise actually decreases the risk for carpal tunnel. Diagnosis for carpal tunnel can often be made by history and physical exam, but sometimes you need to have electrodiagnostic studies also. And electrodiagnostic studies are performed by either neurologists or physical medicine doctors, and they test the signal through the nerves in the arm. They do this with probes that are placed on the hand, and then they stimulate the nerve and test how long it takes that signal to get to the probes. And then sometimes they also need to do an EMG, and an EMG is where they use these small needles that go into the muscles, and then they stimulate the nerve and see how the muscle responds to that as well. So that provides a good objective measure of how severe the nerve entrapment syndrome is, and also helps us to understand if there are other things that are contributing to it, like maybe upstream if there's some neck problems, or sometimes all of the nerves are affected due to underlying problems like diabetes. Steroid injection can also be helpful. Sometimes I use that for diagnosis as well, because if if it's a little bit unclear what's going on and we do a steroid injection, then symptoms should get better. So that confirms it if things get better. If nothing gets better after the steroid injection, that means there's something else going on besides carpal tunnel syndrome, and we need to look elsewhere. So what is not currently recommended are things like MRI, ultrasound, CT scan. And some studies show that they can be useful for a diagnosis, but for the vast majority of people, they're not, and they incur unnecessary costs. They're not currently recommended by our American Association of Orthopaedic Surgeons. Might be in the future. A lot of people ask me that. Do I need an MRI or something for diagnosis? No, there are some signs on MRI that you might have carpal tunnel, but history, physical, and nerve studies are the best way to diagnose it. Treatment. So there's strong evidence that wearing a wrist brace when you're sleeping to hold the wrist in a neutral position and that steroid injections into the carpal tunnel work very well for mild or moderate carpal tunnel syndrome. The purpose of the wrist brace is just to keep the wrist in a neutral position because we know space in the carpal tunnel decreases with wrist flexion and extension. Don't have to wear it during the day, just wear it at night while sleeping. Steroid injection decreases thickening around the tendons that are also in the carpal tunnel. So if we decrease the space that they're occupying, then we make more space for the nerve. So that works well too. Now, they don't cure carpal tunnel. So most likely down the road, symptoms will probably get worse and may require some intervention if it gets bad enough. But it does help symptoms subside in more milder cases. And then oral steroids, so like prednisone pills that you take, those can also help decrease the symptoms of carpal tunnel. But the problem is you can't take them long term because they have lots of side effects. But some people will take them for other reasons and notice, hey, my hand feels a whole lot better while I was taking it, which is true. It decreases all the swelling in the carpal tunnel. What we know doesn't help are things like magnet therapy and medications like ibuprofen, gabapentin. Unfortunately, they just don't help for these nerve problems that are related to compression. And then surgery. So when should you have surgery? Who should have surgery? So everything else that I talk about today, the message is basically deal with it as long as you can, put it off, put surgery off as long as you can, and then have surgery when it gets bad enough that you don't have any other options. Nerve problems like carpal tunnel syndrome, like cubital tunnel syndrome, that's different. You don't want to put that off for an ever because what can happen is the nerve is compressed for so long that there's permanent nerve damage that we can't make any better with surgery. So it's important to understand when it is appropriate to see a doctor, get it evaluated, and maybe consider surgery. So who are the people that I talk to about surgery right away? There are people that have constant numbness and tingling, and those first three fingers and then the ring finger, half the ring finger. If numbness never goes away, if it's always there, then that's a sign that it's more severe. If you have that shrinkage of the thumb muscle or thenar atrophy, that's also a sign that it's severe. And then if we have nerve studies, if we do those, send you to the neurologist and they say, yes, based on our objective findings, there is severe carpal tunnel syndrome, those are all strong indications to have surgery. And then the other indication is if we've tried the wrist brace for a while, we did a steroid injection or two, and it just keeps coming back, well, then it's reasonable to have surgery too, because we know surgery is the definitive treatment for carpal tunnel. And what surgery does is it takes this tight tunnel and it opens it. So we cut the ligament that forms the roof of the tunnel, opens it wide so that the nerve has more space and is no longer pinched. Surgery, there's a couple different ways to do it. One way is open. That's kind of the gold standard where you make an incision. Looks like this picture on the bottom. The incision in most cases is about this big. And through that incision, we can look down at that ligament, cut that ligament, open it wide, and then the nerve and the tendons have much more space, and then close up the incision with sutures. An alternative method would be endoscopic. This picture on top shows that through two little incisions. Sometimes you can use a one incision method, but the difference is you look at the ligament in the carpal tunnel through a scope, through a camera, and then you can cut that through those 2 little incisions. So you don't need a bigger incision. And studies suggest that it's a little bit faster recovery, maybe 3-4 weeks, you get back to work faster. Pain after surgery can be a little bit less than the open procedure. You have smaller scars. If we follow patients out for 3 months or even a year, the outcomes are about the same. So long term, there's no difference. After surgery, you can start moving right away. We want that nerve to start moving and not get stuck in scars. So there's no brace, there's no splint, and you can gradually resume activities as tolerated. It's sore for a while, but it's not, in most cases, a super painful surgery. Cubital tunnel syndrome. So this is a different nerve than carpal tunnel syndrome and a different location. This is the ulnar nerve that's pinched in the elbow. And this results in numbness in the fingers and the hand on different than carpal tunnel. So this is the little finger. This is this half of the ring finger, and then this side of the hand, the back aspect of the hand. That's what this green depicts, where the cubital tunnel affects. And the forearm, that's supplied by a different nerve. So it's just the hand where you get numbness and tingling. Sometimes you have pain in the elbow too, but if pain is the primary problem, not numbness and tingling, it's probably something else that's going on, not a nerve problem. And then in more severe cases, we'll again start to see shrinkage of the muscles in the hand. It's not the thumb muscle like the carpal tunnel, but it's the muscle between the thumb and the index finger here and between the fingers on the back. So you start to see these big kind of divots between the bones. Diagnosis is also made by history and physical. Sometimes electrodiagnostic studies or those nerve studies by neurology are helpful. I tend to get those more for cubital tunnel syndrome than carpal tunnel syndrome because sometimes it's a little bit harder to diagnose. And then ultrasound and MRI, there is some evidence that that is starting to become a better diagnostic tool to evaluate for cubital tunnel syndrome, but still, in most cases, we don't get those studies. This is a picture that shows the difference in where you feel numbness and tingling between carpal tunnel syndrome and cubital tunnel syndrome. So the pink, that's your numbness in carpal tunnel syndrome, and the green, that's your numbness in cubital tunnel syndrome. Another important difference is carpal tunnel syndrome, usually nighttime symptoms, tend to have more wake up in the middle of the night with numb, tingly fingers, whereas cubital tunnel syndrome, usually not so much nighttime, usually more daytime. I hear people are, they sit in bed and hold a book or hold your iPad or talk on the phone for a long period of time, the elbow's in a bent position. That tends to lead to more cubital tunnel syndrome problems. So what do we do for cubital tunnel syndrome? Well, the non-operative treatment is, again, a brace. This brace is going to stop you from bending the elbow. So it doesn't have to be completely straight, but we don't want the elbow pinched all the way up or like sleeping under your arm at nighttime, because that does put more pressure on the nerve in the elbow. So any sort of brace, or the cheap way to do is wrap a towel around your elbow, tape it so that you just can't flex that elbow all the way up at night. That works reasonably well. And then the other thing is just to avoid pressure over the nerve. So that's the inside of the elbow. I tend to see that with people that drive a lot, or truck drivers that rest their elbow on a hard surface or a armrest. Avoidance of pressure over the nerve certainly helps to decrease numbness and tingling there. And then surgery is recommended if the other treatment has failed, or if symptoms are really severe on presentation, like the muscle shrinkage in the hands, that it suggests earlier disease, and we should do surgery to prevent the long-term nerve problems that may not resolve. So there's 2 different ways to do surgery for the nerve. One is just to simply, just like the carpal tunnel, take the pressure off the nerve and then leave the nerve where it is. So that's called a cubital tunnel decompression. Usually need an incision something like this. And through that, you can see the nerve and just release all the tight structures along its path. And so it's nice and free to move in that space. Some people have started to do more of an endoscopic approach to this, just like the carpal tunnel, so through a smaller incision. I'd say most people don't do that now. It's a little bit harder to do that safely in the elbow. But some people will do it. And then the alternative to just decompressing the nerve and leaving it there is to move the nerve. So that's called a transposition. And that requires you to free up the nerve through a longer portion of its path, and then move the nerve in front of this bony portion of the elbow. Usually bury it under a layer of fat or under some muscle. And that's helpful, especially if the nerve is it's unstable, if it's trying to jump over the inside of the elbow on your initial examination. So that works well too. All right, moving on. So now we're going to talk about tendons or tendinopathy. And tendinopathy broadly refers to tendon problems. It's just the umbrella term for it. And what we usually see is that the tendons will degenerate and become thickened in the outer lining. And there are certain locations where those tendons move through tunnels or compartments. And the compartments are made of this tough fibrous tissue. And so the compartments themselves will also become thickened. So you have this thickened tendon trying to glide through a thickened compartment, which results in friction and inflammation, pain, and sometimes some reduced motion because of it. Trigger finger, this is a tendon problem. The medical word for this is stenosing tenosynovitis. Trigger finger is a lot easier to say. So each finger has two tendons that bend the fingers, and those tendons live in a tunnel. So this picture up here shows the start of the tunnel, and there are these things called pulleys, which are these tight fibrous bands that hold the tendon down to the bone. And so right at the entrance of the tunnel, or kind of right at the base of the finger in the palm, that's where that first pulley is at. That's the problem pulley and trigger finger. What happens over time is the pulley thickens, the tendon kind of thickens there, and then it hurts, and it can also get stuck. So as you bend the finger, you're gripping things tightly, then that finger gets stuck down, and you have to pop it out free, or maybe even manually release it to make it go straight. So we call that catching or clicking, and sometimes locking of the finger. This is also very common. We see it in 3% of the general population and up to 20% of patients that have diabetes. For whatever reason, the tendon lining tends to be thicker and be more prone to inflammation in patients that have diabetes. We also see it in middle-aged females for whatever reason, and it usually affects the thumb and the ring finger, but it can affect any finger, and sometimes there are multiple fingers that are affected. Sometimes we see it in association with things like carpal tunnel syndrome or Quervain's tenosynovitis, which I'll talk about next. And all of these are basically a size mismatch. That's why they happen. You have something in a space that's too small for it, usually because of some underlying degeneration where the tendons get thicker. So risk factors, so diabetes is a risk factor, but also anything where you're doing repetitive gripping forcefully, that can lead to a trigger finger. I had one patient, I think he was an Iowa State grad student, who was a competitive table tennis player. So he was holding this ping pong paddle in his hand and playing several hours a day, and he developed a trigger finger in his middle finger because that's really important for grip. So things like that, or doing a lot of gardening, that can also contribute to the development of a trigger finger. History and exam are enough to diagnose this. We don't need any special studies. And treatment for it. So most patients that present with a trigger finger will proceed with a steroid injection. And a steroid injection works really well for tendon problems. For some patients, it'll cure it. It won't come back. So in contrast to arthritis, where it will come back and we do an injection every 3 or 4 months, we don't have to do that with tendon problems. One injection may be enough. Now, it's not always. Sometimes it'll come back, and then we can always do another injection. And there's good evidence that shows that 2 injections is really effective. So we perhaps do 2 injections and then it goes away. Some patients, it keeps coming back, and that tends to happen more with diabetic patients. So if we get to 3 injections, it keeps coming back, then we consider surgery, which is effective if we get to that point. There's also some evidence that supports the use of a finger brace as well as some guided therapy and anti-inflammatory medications. So for my patients who really don't want to do an injection, that's a reasonable option. The problem is the brace looks something like this or like this, and it's going to stop you from bending the finger fully, which isn't all that functional. So you may realize that it's really hard to be compliant with a brace like that, especially during the day. So some patients will just wear it at night when they're sleeping, and that can be effective. Surgery. So what do we do for surgery? Well, much like carpal tunnel syndrome, you've got a tight tunnel. You simply cut the pulley, open the tunnel so that the tendon can glide. And sometimes we can do this with a needle in clinic under some local anesthetic. So that's called a percutaneous release. You get a little bit bigger needle and you can use it sort of like a knife and kind of feel that pulley cut. Works okay. You have to have the finger locking to do it because that's the only way we know if we actually got it released. If we cut it and you can reproduce that locking, well, it's not fully released, so we have to keep working at it. So it works okay. And then the gold standard is an open release of that pulley through a small incision, but usually done in the operating room. So higher cost, a little bit longer recovery time because of the incision that needs to heal. Quervain's tenosynovitis. So this is the second hardest word to say in my talk today. We'll get to the hardest word later on. But so this is much like a trigger finger, but it's just in the wrist. So the wrist has different compartments that house tendons on the back of the wrist. And this is the first compartment. So this is at the base of the thumb. There's two tendons that move the thumb, and they glide through this tight compartment, and it causes pain, sometimes some swelling, and a lot of tenderness right at this location where he's putting his thumb. Symptoms, we talked about that, risk factors. So if you're doing things where repetitive activity, where you're moving the wrist in a position like this, that can cause it. We see it a lot in young moms that are picking up their kids over and over again. But you can get it later on too, just from some degeneration. History and physical are adequate for diagnosis. And then treatment, so all the same things, use of a brace to immobilize the wrist and the thumb, steroid injection, anti-inflammatory medication. That's successful for the vast majority of patients. Occasionally, we do a few injections, it just keeps coming back, and then we can do surgery to open that tunnel. But most patients never need to have that surgery. Gout and pseudogout. So this is crystal arthropathy. So this is relatively common as we get older, and especially pseudogout. Pseudogout is just a different crystal than gout. Gout is uric acid, pseudogout is calcium pyrophosphate. So if those crystals deposit inside the joint, it's very painful. It can cause swelling, it can cause redness. Sort of looks like an infection, but it's not. Risk factors for gout, those are all these things, and people that develop gout have more of a propensity to develop gout later on, and it usually affects the big toe. That's the most common location, but you can also have it in the wrist and occasionally in some of the smaller joints of the hand. Pseudogout, that's more associated with just older age. Sometimes it's related to some recent trauma, but doesn't have the same risk factors like alcohol and red meat that gout does. So diagnosis is made with history, with physical exam, but this is one in most cases we do want to draw some fluid out of the joint in order to analyze that and see the crystals. And that's usually because it looks like infection. So if it's infection, that's a much different treatment than gout or pseudogout is, which can be managed usually with medications. Infection typically requires surgery. So drawing fluid out, analyzing it in the lab really helps us to differentiate the two. And then treatment. So if it is gout or pseudogout, then that gets better with medication. And that medication is things like steroids, oral steroids, colchicine. And then we can also use medications that help prevent gouty attacks in the future. A lot of times I'll see patients that have this happen and maybe it takes them a couple weeks to actually get to see me. And it's typically pseudogout when that happens because by then things are feeling better. So given enough time, it will typically resolve on its own. Mucous cyst, so a digital mucous cyst. This is a ganglion cyst of the small joint just below the fingernail. And usually what you see is a little bump. It can look like this, or it might be a little more subtle and look like this right below the nail fold. But that cyst will sit right on the nail matrix, and so it can cause a divot in the nail. You get this grooving here in the nail. Doesn't always do that, but it's pretty common. The underlying problem is some arthritis within the joint itself that's producing this cyst. And so the only way to really get rid of it is surgery, where we open it up, take that cyst out, and then clean the joint up a little bit so that it no longer can produce this cyst. Sometimes patients will get this, they'll go see their doctor or they'll go see the dermatologist and they'll try to stick a needle in it and draw fluid out. It just doesn't work for mucus cysts like this. That does work for ganglion cysts in other locations, but not this one. So treatment, you either live with it, especially if it doesn't hurt and you don't care about the nail, or surgery to take it out. This is the hardest word to say. So this is Dupuytren's disease, also very hard to spell. I think it took me 10 years, but I can spell it now. So normal anatomy, there's fascia under our skin, and that fascia anchors the skin so that it doesn't shear. But Dupuytren's is when the cells of the fascia will mutate. So they become fibrotic. Usually notice these little lumps in the palm. They're pretty firm and right under the skin. And then they also can develop into cords, and the cords go longitudinally in line with the finger. And it doesn't hurt in most cases, although sometimes nodules can be a little uncomfortable, maybe cause some itching in the beginning, but that usually goes away relatively quickly. Most patients just come in and they say, "What is this lump in my hand? I just noticed it recently and I'm not sure what it is." In most cases, it's Dupuytren's disease. It's very common in this location of the country. It's very common in white people. It's much less common in other races. There's a genetic component to it. So often people will have brothers and sisters and uncles and aunts and parents that have it as well. The ring finger and the small finger are most commonly affected, but you can get it in the thumb, you can get it in the index finger or middle finger as well. It doesn't go above the palm. It's just in the palm. Risk factors. So diabetes is a risk factor, psoriasis, high cholesterol, smoking, heavy alcohol use. Those are all risk factors. But for the most part, unless you have uncontrolled diabetes, you drink a lot, you can't do anything to really make it worse or make it accelerate faster. You also can't do anything to slow it down. It will run its course, and the only thing that we do is treat it when the contracture becomes a problem. So if it's just a nodule, just a lump, or just a cord, but you can get your fingers fully straight, then we just keep an eye on it. No intervention is necessary. The reason to intervene is when it starts to contract the finger, bring the finger down into the palm. So a useful test is if you can put your hand flat on the table, then you don't need any intervention. We call that the tabletop test. If you can't get the hand flat, then it's too contracted, and then we can intervene with either a special enzyme injection or surgery, which can break up the cord. It always comes back, but that will provide several years of relief before it comes back. And so this next slide is just the Xiaflex injection, which is that enzyme, or surgery, which is open it up, cut the cord out. Both work pretty well. Surgery just lasts longer. So that's my talk today. Hopefully that was helpful. I think the biggest takeaway I'd say is don't ignore your numbness and tingling. It's very common as we get older to develop some nerve entrapment syndromes, and surgery is very beneficial, and it's usually not all that difficult, not all that hard of recovery. And everything else, aches and pains in the joints and stuff, there's treatment for it, but if you can live with it, live with it. And then come see a doctor if you want a steroid injection or maybe discuss some surgery.
All right, I have a microphone for questions, so just go ahead and raise your hand and I will come around. And we have our first question here.
You said that perhaps sometimes exercise is good. Do you have any specific hand exercises that could help either delay these things or just help you?
I said, yeah, so that's in reference to carpal tunnel syndrome. They do different studies to evaluate risk factors associated with it. So when we talk about exercise related to carpal tunnel, it's not specific hand exercises, but just exercise in general. And I think the reason why is because lower BMI, we know, decreases risk of carpal tunnel syndrome. So hand exercises specifically to reduce the risk of these things? No, not really, honestly. Sometimes for physical therapy, especially with cubital tunnel syndrome, so the nerve in the elbow, you can do nerve glide exercises. I'm not an expert in those, but the idea is stretch the shoulder, stretch the elbow, stretch the wrist, and you're getting the most length out of that nerve and trying to really move it through the whole length of the nerve from the neck to the arm. A hand therapist would be much better at explaining those things. But yes, so nerve gliding exercises are about the only specific ones to help with nerve problems.
I've got two questions. My first is, do you have any suggestions or ideas about like hand cramps? It's like sometimes I get like this, it feels like the claw. And it feels like a Charlie horse, like you get in your leg, but in the hand. Is there anything that would trigger that?
That's a hard one. I do see some patients that come in with the primary complaint of hand cramps. And what I'll tell you is most of the time, there isn't a specific like structural cause for it. It can be related to some underlying metabolite problems, like that maybe some blood work could be helpful for. A lot of times in younger people, it's related to overuse. So anything where you're having to do repetitive gripping and lifting, it's related to that. Occasionally, it is related to some nerve problems, but most of the time it's not. So it's a hard one, though. It's not. There's no easy way to diagnose that.
Okay, great, thanks. And my other question, with the trigger finger, are you seeing an increase in older people playing pickleball having trigger finger?
I haven't. I don't know why. I think that, yeah, that probably there are more pickleball players and therefore likely more trigger fingers. But no one's come with that specific correlation yet.
All right. Another question here.
Yeah, thank you for your presentation. How does that BMI indicate more concerns?
Yeah, for carpal tunnel syndrome. Why does it? Good question. I don't know. I'm not sure if so when you look surgically, when you look inside the carpal tunnel, does it look any different in a patient that has a large BMI versus a lower BMI? No, it looks the same. So why does that make it worse? I don't know. I'm not sure that we know why, but it does for whatever reason.
And thank you. And then I have a couple more. How does the gardening make it worse?
That would be from repetitive gripping. And it's not so much that that's a problem affecting the nerve itself. The problem is the tendons. So that space is shared by the tendons that flex the fingers and the nerve. So if you're doing a lot to aggravate the tendons and they get thickened and inflamed, you have that space that doesn't get any bigger. You decrease the space for the nerve because the tendons get thicker and then the nerve gets pinched. So that's the reason why, but it's that repetitive gripping related to gardening that can be a contributing factor.
And then after you've had a surgery, does it mean there's certain things you can't do or you're free to go? How does it change what you can and can't do? And thanks for your presentation.
Are you talking about carpal tunnel specifically?
Yeah.
You can do whatever you want. There are no restrictions after surgery. So, once things have healed up. In the beginning, I tell people to take it kind of easy. What I don't want them to do is, I had one patient, so I used to be in the Army as an orthopedic surgeon. So those guys are really motivated sometimes. So I did bilateral carpal tunnel release on this major, and he came back for his first post-operative visit like a week later and was doing push-ups, that's the wrong thing to do. So don't do that. And the reason why is we don't want it to bleed into that space and get inflamed and compress the nerve and just slow down healing. But after 4 to 6 weeks, you can do whatever you want to do. Most of that soreness and scar tenderness goes away by about 3 months after surgery. And then there are no restrictions. It typically does not come back, but it can. You cut that ligament, it takes this space, opens it to here, and then it scars from here to here. So theoretically, you could get carpal tunnel again, but most people don't.
All right, another question over here.
Thank you. In your surgical practice, being described as hand and upper extremity, I think it was, what is considered upper extremity? Does it just go to the elbow? Does it go to the shoulder?
So most people, when they say that, will include shoulder. So I do some shoulder stuff, like shoulder replacements, but like rotator cuff repairs and labral repairs and other things that are done through a scope. I did a lot of that in the Army, but I don't do it here because we have other surgeons that do a lot of that. So I mostly do, most of my practice is hand and wrist, and then elbow stuff. I'll do fractures, I'll do nerve stuff, tendon problems, and then a little bit on the shoulder.
So then with a follow-up question with regard to the shoulder, are there things in the shoulder that can also affect numbness in the last 2 fingers?
So most of the time, no. Now there are some exceptions to that. Like let's say there's a mass, maybe a tumor or something, that can certainly compress the nerves, but that's pretty rare. We see nerve problems occasionally after shoulder replacement surgery because sometimes what happens is you lengthen the arm because of the implants that you put in, which stretches the nerves. So that can happen. But in the absence of those 2 things, typically you don't have an isolated shoulder problem that causes numbness and tingling in the hand. Yeah.
All right, any other questions? Am I missing anyone? And Tim, still no questions online?
Nope.
Okay, well, you did an excellent presentation. Lots of good questions today. Thank you, Dr. Bean, for joining us. Just want to remind everybody of some upcoming programs that we have. Thursday, we jumped to later in the month. Thursday, September 29th at 2 o'clock, we have one on easy ways to make vegetables taste great. And then Tuesday, October 4th, we have CPR and AED, shockingly easy. And that program will only be in person because you will have mannequins and stuff that you'll get to use. And then up at the back of the table, I wanted to draw your attention. Story County Public Health, which is part of our home health department here, is doing a several week, I think 9-week program on unlocking brain fitness. It's every Thursday starting September 15th to November 17th down at the Ames Public Library. You need to sign up. There's information on the flyer on how to sign up, but should be a good program if you're interested in that. So once again, thank you, Dr. Bean. Thank you, everybody, for coming out today, and have a great day.